everyone. Welcome to the Animal Heartbeat. I'm Jose and Novo Matos, and I'm here as usual with Kieran and Borgea. We are professional veterinary cardiologists and amateur podcasters.
Very amateur podcasters.
Very. We have a great episode today, as again, we have a very special guest. We have here today with us Professor Gerhard Wess. I'm sure that everyone listening to this episode will know Gerhard. Gerhard is a professor of veterinary cardiology at the University of Munich, Germany. And Gerhard did two residencies. First, one internal medicine residency in Zurich, and then he did a cardiology residency at UC Davis, California. So Gerhard is a truly double-boarded specialist. Gerhard has a very large research output, has published in many areas, but with a special focus on dilated cardiomyopathy. And he has recently chaired the first European Society of Veterinary Cardiology guidelines for screening DCM in Dobermans. Welcome, Gerhard. It's a pleasure to have you here.
Thank you for the invitation. It's a pleasure to be here.
I thought we could start talking about staging of dilated cardiomyopathy. You have recently written a nice review paper for a special edition at the Journal of Veterinary Cardiology, where you propose a staging system for dilated cardiomyopathy similar to the one published in the guideline for mitral valve disease. There might be a slightly difference on how you have classified stage B1 and B2 in comparison with mitral valve disease. Would you like to guide us through that staging system? How would you define stage B in a DCM dog?
Sure. Stage B is an asymptomatic stage in mitral valve disease, as we all know. And when I was writing my papers, I was always coming to that conclusion what to do with syncope, because syncope obviously is a symptom that the owner can recognize. And then we said, in the occult phase, you can have syncope, which doesn't make sense. So that would be also included in stage B, because the definition that I would propose is in stage B is no signs of congestive heart failure. And therefore, syncope would be allowed in stage B. And then the differentiation between B1 and B2 would be that B1 are the dogs with arrhythmias and without echocardiographic detectable changes. So a boxer with VPCs, a Doberman with VPCs, or an Irish Wolfhound with atrial fibrillation. So we can put them into stage B1, and then everybody knows, okay, this is a dog that has only arrhythmias. And then in stage B, they have echocardiographically detectable changes.
So that would potentially mean that a dog in stage B could still experience sudden cardiac death.
Oh, for sure.
Yeah.
I mean, we know that from many studies, from Clay Calvert, from Mike O'Grady, these two great Doberman researchers, and they always said, well, a Doberman in the occult phase can die suddenly. This is our major problem, because the owner doesn't know that the dog is affected unless they come for screening, but the dog drops dead.
I think there's huge challenges in this early phase in dilated cardiomyopathy, because mitral valve disease is easy, isn't it? Stage B, they have a murmur. The dog's saying, hi, I've got heart disease, please investigate me. Whereas with dilated cardiomyopathy, there are no outward signs. Many of them don't have a murmur. And therefore, who do we screen? Who's most at risk, and how do we look for that disease? And that may be a ridiculously broad question to ask, but that's something that I find really challenging to answer when people ask me that question. So what's your opinion, Gerhard? Do you stratify risk based on breed, based on age? How do you look at that?
Absolutely. And I think this is why we also have stage A. Stage A are the breeds that raise the awareness for general practitioners, for owners, for breeders. Hey, here are breeds that have a high risk to develop the disease. The classical examples would be Dobermans, Boxers, Irish Wolfhounds, Great Danes, maybe Newfoundlands, San Bernards. So all these large breed dogs, when we say in mitral valve, we have the small breed dogs. Here we are talking about the large breed dogs that have this high risk to develop the disease. And then by educating owners and also breeders and veterinarians, we can promote screening exams. And in certain breeds where we have a prevalence of 30% or over 50%, that absolutely makes sense.
Right.
I can tell you one story about screening. When I came here in 2003, wow, that's already 20 years ago.
Congratulations.
I was a young researcher. And so you start at the university and you have to pick a research topic. So I thought, okay, Dobermans. When I was young, we had Dobermans and I worked with clay culvert. So it was kind of clear, okay, that would be a topic that I was interested in. And then how do you start research? Well, you call up the breeding association and they said, Dobermans and DCM? Nah, we don't have a problem with that. The German Doberman, well, they are healthy. And then you say, okay, but you don't give up. At that time, we had already internet. So you go to the internet and start to search in the forums, and then you search, and there was no news about DCM in Germany, but then you can see Arco. My friends, I have to tell you, Arco yesterday went over the Rainbow Bridge. He just dropped dead playing on the grass. And it was probably one of these deadly snake bites. And that raised my attention because that was a perfect research topic, because we don't have deadly snakes in Germany. So either I find this Doberman viper that nobody has ever detected, or the disease is there. And actually, that was the case. And then after many, many years, the German breeding association, they finally agreed on doing some screening exams, but they did that by themselves. Unorganized, without the help of any cardiologist. They just had cardiologists doing the exams. And then they came up with a prevalence of 3%.
Wow.
And then they said, you see, we don't have DCM in Germany. Yeah, but then we looked at that and they only performed screening exams in very young dogs, in 1 or 2 years old,
right?
Which is way too early to detect the disease. And that is when we came up with our data in the different age groups, just to show them where does it make sense to screen and how high the prevalence is. And we came up with a prevalence in Germany or around here in Central Europe of about 58%.
That's wildly high, isn't it?
Huge,
compared to the background data that was provided previously.
Yeah.
But that's a good starting point, Gerhard. That's great. Just to remind our listeners, so as we discussed with HCM, cardiomyopathies in general have an age-dependent penetrance. So it's more likely for the individual to develop the phenotype as they get older. So Gerhard, if we would ask you a cutoff age, an age where we would say you should start screening your Dobies, what would that age be?
I would suggest to start with 3 years. And then what is very, very important, but you all guys know that, is to repeat that exam. Right. Some breeders are just coming to get that stamp, yes, approved by LMU, my dog is healthy. No, it's not. I would wish we have breeding certificates that is like a Snapchat. It disappears after 1 year. Right. From the internet. That would be great. But the good breeders, and there are a lot of good breeders, they come yearly. And if there are financial concerns, I would suggest that if a dog is in the breeding program, that you do yearly exams, and especially the males, because of the high potential to spread the disease, and the female dogs at least every 2nd year. If money would not matter that much, yearly exams, that would be perfect.
Difficulty with engagement with annual examination. It's something that I think we face certainly in the UK, and I'm sure people all over the world face these difficulties. So obviously this screening in youth for congenital heart disease is fine. But as soon as we start thinking about any of the common diseases, these very, very widespread acquired diseases, it's a massive problem. And I think this is one of the reasons people are super interested in genetics. Potentially that could provide a test that stratified risk somehow in youth, but we all know it's not that simple. What are your thoughts on the current status of genetic understanding of DCM, is there an opportunity for using genetics to screen, or is this something that actually at the moment we don't know enough about?
We had performed a full genome study a couple of years ago and found something on chromosome 5. But that only means you find the highway. The next step is to find which parking spot did I lose my key.
Nice.
So right now we knew the highway, and now recently, and it's not yet published, but it's very late in the process. We did a even bigger study, again a multi-center study, and we had some great geneticists involved, and that actually confirmed that we have something on chromosome 5. Interestingly, it appears also that this is also a new mutation that in some humans can occur, and they didn't know yet.
Wow.
So then on the next step, we tested some human patients.
Huh.
They seem also to benefit from the research. And
Amazing.
that will come out in the near future, hopefully, in a human journal.
Wow.
From our side, what we can say is it's not easy. We probably can explain the DCM phenotype. So where you have the echocardiographic changes, the arrhythmias, we cannot explain that good. So it will be not easy that there will be a genetic test and it's working. And so therefore the screening will remain for a long time until we find a solution for that. But it's super difficult to find that correct genetic mutation.
That sounds very cool. Just to stress to our listeners, so you have shown, so there's a genetic test available for Dobie's, the PDK4 gene mutation. Which can you explain us a bit your data on that? Because you have shown that there are probably some geographical differences potentially between Dobie's affected by that mutation. Is that right? So is there a different genetic pool between Europe and the US, or not really?
We did not look at the geographic differences. We just have Dobermans coming from Europe, not only from Germany, but from the countries around. And what I can say is in the first full genome study, we found only a signal on chromosome 5 and nothing on chromosome 4, where the PDK4 is located. We tested our population on the PDK4, and it did not mean anything. And also in the latest research that we did, there was again no signal on chromosome 14. I cannot comment on the American population. Maybe it's working there. Maybe it's not working. But in Central Europe, unfortunately, I know that it is not working.
It certainly wouldn't be surprising for there to be differences in different populations, would it, based on what we know about humans, but also about boxer dogs and striatin, and the data from the US on striatin suggesting it's causative, and then the data from the UK and Europe suggesting that it might be co-inherited at best with a causative mutation rather than being causative itself. It's so nuanced and complex. If we understood the factors that switch on the disease, maybe that's more important than understanding the genetics itself. Because if these causative, these trigger factors that might switch the genes on are easier to understand, then maybe we don't need to understand the genetic basis. Do we know of any environmental factors that are associated with dilated cardiomyopathy in dogs? Is that something we should be looking for or thinking about, rather than doing this complicated safari for genes that we may never understand?
Very difficult topic. So far, we didn't, at least my group, we did not find any trigger. But then on the other side, we found autoantibodies against some receptors, which we can treat with aptamers. And then they had a much longer survival time. And so you don't know which came first. Was it a genetic defect? And then maybe these autoantibodies came there. Maybe there is an immune component to the disease. And I was thinking maybe that's the case. But it's for sure it's genetics, because otherwise you don't get a prevalence of 50%. And why do you only get it in Dobermans with 50%? And in other large breeds dogs, they don't have that. They also should have these environmental influencing things. I'm sure there are some cofactors, and we just don't know exactly which ones are there.
So thinking about non-genetic factors that some data support being associated with DCM, I'm thinking about nutrition, and it's a reasonably hot topic at the moment, certainly from the US, that there may be an association between high legume diets or grain-free diets and the development of a dilated cardiomyopathy phenotype. So my personal experience of this is I almost find it impossible to buy dog food for my own dog in the UK that's not grain-free. Most of the dogs that I see in this country are on, 50%, 60% are on grain-free diets. I've never seen a case that I believe is nutritionally associated cardiomyopathy. What's your experience, Gerhard, and what are your thoughts based on the data that's out there?
All right. I mean, we all agree that Cocker Spaniels have taurine deficiencies.
Sure.
And we all have seen that. And there, I think, is no doubt they get a taurine deficiency, despite the fact that it's in the literature taurine plus carnitine deficiency, because at that time it was en vogue to give carnitine at the same time. But all our Cocker Spaniels get better on taurine supplementations alone, if we prove they have a taurine deficiency. Cocker Spaniel is not a large breed dog, so they are special anyways. Concerning the dietary induced cardiomyopathy, we have seen some cases also in Dobermans. In Germany, it's not that high, the amount of food that not 50% of the dog foods are grain-free, but a lot of people are feeding grain-free. When we diagnose DCM, we always talk to the owners. We already talk before with them about food, and my team is very eager to ask all that thing. And then sometimes I say, yeah, it's a mitral valve dog. You don't need to talk so much about grain-free diets. But because they are trained to talk so much about diets, we do that. And actually, we started even a study in our Doberman population, because we wanted to see if there is an influence on it. The problem is, in the moment when you talk about, we are performing a study on Dobermans on grain-free diets, and potentially there is a influencing factor. Now, most of the Dobermans that come to us, they are already switched because of internet. They read about a study, and then the community among these Doberman owners, they are so highly connected, and then they say, they think there might be a connection, so I just switch my diet. So all these follow-up studies we could not do anymore, because we wanted then to change the dogs to a normal diet, but the owners already changed them.
Wow.
What we sometimes see is also in the Doberman, some taurine deficiency, but not very common. That would be really rare. In other breeds, we diagnose taurine deficiency even on dogs that were barfed.
Right, okay.
Where you think, wow, that's strange.
If the one thing they've got is taurine, right?
Yeah. But it seems to be the combination of whatever they give and certain kind of meats. We had also, like in the literature, some dogs that were on grain-free diets, and they became better after we changed the diet. I would not say it's a huge amount, but usually when we diagnose DCM, we try to search for an underlying cause. Is it tachycardia-induced cardiomyopathy, especially if you have a breed that does not fit? Like you have a young Labrador and he shows up has on echo a DCM phenotype, and then he has a supraventricular tachycardia. And often I think people would guess, the supraventricular tachycardia is secondary to the DCM, but it's actually that they have re-entry tachycardias, and that was actually the cause. How do I know? Because we treated it and it was reversible. And many of us have seen those cases. So we are searching for tachycardia-induced cardiomyopathy. We are searching for especially food influencers. And then we measure taurine usually, and we try to change the diet anyways to a normal commercial diet.
So would you halter every dog that you diagnose with DCM, irrespective of breed?
Not necessarily, especially the breeds where you don't expect it. If it's a street dog,
Sure.
not a purebred dog that shows up with DCM phenotype, then I would do that.
Yeah. Okay.
Or if they are especially young, or and then the other breeds, I think it is not a bad idea to halter them if it's financially doable. A Great Dane can have VPC, Doberman, Boxer, all these other breeds, and often you don't see them during the echo or during a short-term ECG.
Sure.
Just regarding phenocopies, because as you were saying, Gerhard, there are a couple of DCM mimickers, diseases that may mimic DCM that are not familial or genetic. And you already mentioned some of those. You published some interesting work on hypothyroidism on dogies. And so, as pretty much every listener will know, hypothyroidism may potentially cause left ventricular systolic dysfunction and may be a mimicker of DCM. What is cool about Dobermans is they have a high prevalence of both DCM and hypothyroidism. And you have looked into that. Can you just summarize your findings to us, please?
Yeah, as you said, we had, for example, the reason why we did that study was Dobermans are sometimes diagnosed with both, with DCM and hypothyroidism, which sometimes I think is a challenge, how to test that a dog that has an advanced DCM, that they have not euthyroid 6 syndrome. Just measuring T4 might be a problem, but for that study, we did a lot of thyroid tests. So we were sure that those dogs that we diagnosed actually had hypothyroidism, and the prevalence was actually quite high. Some of them also had DCM. And the reason why we had started that study was that often we got cases back, we diagnosed DCM, and then the home vet maybe later made a test for hypothyroidism, and then they stopped the cardiac medication because the implementation was, it's just hypothyroidism induced or mimicking DCM. So I wanted to see if that is real or not. And the outcome was actually they're unrelated. So a hypothyroid dog, if you treat them and you manage them, you would think the DCM is reversible, but it was not. It was actually progressing. The VPCs progressed, the heart get larger. You could again speculate about an immune component. Maybe hypothyroidism has an immune component to it, and maybe the DCM with our autoantibodies, for example, also. So maybe they have something on a gene in common that manipulates the immune system so that they have again, a trigger to develop either the DCM or the hypothyroidism. I don't know. This is pure speculation, but it's
interesting idea though.
Yeah, but that's cool. But so you showed that hyperthyroidism is not the etiology, the cause of DCM, and doesn't affect progression. Would you, in your clinical practice, would you still measure T4 and TSH in a Dobie that has a DCM phenotype on echo, or would you only do that if they have clinical signs suggestive of hyperthyroidism?
We only do that when they have clinical signs.
Yeah. Kieran started talking about halters, and we would like to have your input in a couple of things. DCM in Dobies may have two different components: an electrical dearrangement where you only have arrhythmias, or a morphological dearrangement where you have a dilated hypocontractile ventricle, or you can have both. And so halters are really important, as everyone knows, to diagnose the electrical component if we want. So on your guidelines, the European Society of Veterinary Cardiology guidelines, you describe the cutoffs very neatly. Do you think it plays a role, or would you do a 24 hours or a 48 hours halter? Do you think it does play a role to do a longer halter to detect ventricular arrhythmias in dogs. Do you have any data on that, or what are your thoughts? Do you do 24 or do you do 48 hours?
We do at the moment still 24 hours. There was a recent paper that showed that if you do it longer, 48 or 72 hours, of course, you have a higher chance to detect some arrhythmias, and there's a day-to-day variability. I think it also has to be manageable. We see every week like 10 Dobermans, and we have to analyze all these halters, and we have to have the devices back. So just practically, we stick at the moment with 24 hours, and probably the number of VPCs or the malignancy of that you detect only on a 48-hour ECG is probably not that dangerous, because if they have a lot and if they are dangerous, you usually see them on 24 hours.
I tend to run 36 hours just because I'm annoying, and I exclude the trip to the vet. I'll take out the trip to the vet and the journey home when I'm looking at AF heart rate, for example, or I want to interpret, were those 1 or 2 VPCs that I saw when the dog was very stressed on the echo table, were they important when the dog's at home? I would say that, having looked at that data quite a lot, I've not analyzed it, but just my impression is that the worst arrhythmias are in that first 12 hours because of the catecholamine effect. I don't think that would lead to overdiagnosis, because I think the substrate for the arrhythmia is the DCM, is the disease. But I think when the trigger, the catecholamine, is there, that brings it out and helps you to see it. So from my point of view, I would imagine that 48-hour halter is probably not going to help any more than a 24-hour halter. But it's interesting to see how different people work and what their thoughts are.
The tricky thing is we don't really know day-to-day variability of VPCs in Dobermans. I don't know if you have any data on that, Gerhard. So we still use the data from boxers and the human data on 85% variability or something like that. Is that right? Do you think Dobies might be different, or do you have a feeling that the day-to-day variability might be similar?
We looked at those data, but unfortunately, I don't have them present at the moment. But yes, we looked at the day-to-day variability. It's there, especially in the low numbers. Okay. Because, I mean, that's kind of clear that if you have a difference between 100 and 150, this is a huge difference, but clinically it's not. And the same does it matter if you have 2,000 or 4,000 VPCs? It does not. It's
a statistical difference, isn't it? Not a clinical difference.
Your question probably goes towards treatment later. How do we judge if we were successful? And we are not looking at numbers. We are looking at malignancy criteria that predict sudden cardiac death.
Yeah. Honestly, we should start talk already about that, because we want to talk to you a lot about echo, but that's the hot topic. Let's talk about sudden cardiac death, because that's the big thing. That's the big thing, isn't it? And then we go
JJ's been itching to talk about dogs dropping dead. Yeah,
exactly. If that's all right with you guys. So you have this very cool study with very cool stats on predicting sudden cardiac deaths in Dobermans. And then we are talking about halters. If I remember right, the total number of VPCs did not play a role. It was not a risk factor for sudden cardiac death, was malignancy, how fast the VPCs were, and so on. But I still wanted to ask you that, does number matters or not at all? 3,000 or 8,000 VPCs?
That's correct. Why should 2,000 slow VPCs be more malignant or be having a higher risk to die suddenly compared to 100 very fast ones? I mean, where you have the danger of R on T phenomenon. And that study actually showed it. From all these studies that we did, this, I think, is one of the coolest, because in that study, we compared dogs with DCM to dogs with DCM. Some of them survived 1 year, and the other ones died within 3 months after the last exam. And we halter all our dogs, and in our Doberman study, ongoing now since almost 20 years, they come yearly back, and they get very special rates. So they are coming back because it's very cheap. So we have a lot of data. Then, as you think, in some breeds, it says, yeah, we start treatment with more than 1,000 VPCs in boxers. Where's that number coming from? Somebody thought 1,000. Yeah, let's take 1,000.
Someone chose a number, right?
Yeah, it's just a random number.
Yeah.
And if you would ask somebody, what is the most dangerous thing in a Doberman? You have two Dobermans. Like today is Tuesday. Today we have like 5 Dobermans downstairs.
When is can you tell us about the D-Day? I heard about the famous D-Day.
The D-Day. Well, the famous D-Day is Tuesdays and Fridays. They are coming on.
I'm so sorry, we are taking you from
We're taking you away from the Dobermans.
Really
oh, the irony, the irony.
All right. So they are coming on Tuesdays and Fridays, and because they are a lot of work, then we call them maybe the D-Day. So today is D-Day, and there are 5 Dobermans downstairs. 2 of them are maybe diagnosed with DCM, and then 1 might die in the next few weeks. And we were always wondering, how can we predict the risk to die suddenly? And if you think about it, if you compare dogs that die suddenly, as it is done in most studies, to a healthy controlled population of healthy Dobermans, statistically, everything will come up that defines the disease.
Sure.
So that was not the cool thing. So we selected dogs that died within 3 months and compared them to Dobermans with DCM diagnosis that survived at least 1 year on follow-up. And then this special software statistical tests generated thousands of decision trees. And the thing that was always in all these trees came up on top was actually cardiac size. And it was left ventricular end diastolic volume, but that is only a representative of the DCM phenotype.
Right.
We tried separately, can you use end systolic volume or ejection fraction or NT-proBNP as a predictor of echocardiographic changes? All of them you could not analyze separately because they go parallel. A dog that has a typical phenotype DCM, a big heart with a poor contractility, that is the major risk factor. And the software then calculated cutoff values for Dobermans, and basically it found if the heart is normal sized, the only predictor of sudden cardiac death was if they had VTACs. Right. If the heart was enlarged, then the next decision trigger was the beat to beat frequency, the Vmax. We entered 26 different Holter criteria into that. The amount of couplets, triplets, whatever, 26 Holter criteria. And we gave them all the echo data and biomarkers, and then it was calculating. So basically, the second most important thing, if the heart is enlarged, was the beat to beat frequency of the fastest VPC. If that was more than 260, these dogs had a very high risk to die suddenly. So there we have this magic number. And it actually changed also a little bit the way how I'm looking now at our Dobermans. They are all in prospective studies. So I'm not changing them now and change the classification because they are still in the study. But already at the beginning, it was kind of the correct criteria how we categorize malignant, or sometimes we call it benign arrhythmias. They are not benign, but they are not as malignant as the other ones. Then sometimes when we are on the borderline, I'm always asking, so how big is the heart? How is the contractility? If the heart is still normal, I'm not so pushy anymore to treat them with antiarrhythmics versus the heart has the DCM phenotype, it's pretty big, and they have fast VPCs, they have to be treated, otherwise they die.
That's really interesting because I think instinctively we all look at Holter criteria and say, oh, well, this dog's higher risk because the arrhythmia looks like this. we should be contextualizing that in the echo findings and how marked the changes are on the echo. I guess that reflects the severity or the I guess that reflects the substrate, and the arrhythmia is the trigger, maybe, or the combination is important.
Gerhard, you have a crazy amount of data out there on echo diagnosis of DCM and so on. And of course, echo is the gold standard, and that's how we're going to diagnose the disease. So volumes versus linear measurements. Would you still measure the left ventricle with a simple linear dimension, or you just really rely on volumes?
There are two different things. Do we still measure? Yes. We still measure M mode.
Do you use them? No.
And we are also looking at the diameter.
Okay.
There is one very, very important thing that is sometimes forgotten, because there's a wealth of data on normalized values. And for mitral valve, everybody uses either the Cornell or the ESSER data to normalize LVIDDN. In Dobermans, this is not working. In Dobermans, we have much better breed-specific data. And I just, like this morning, I had a dog where LVIDDN was normal, but actually the dog had DCM because he was above even the M mode cutoff values, and also on Simpson. So don't use LVIDDN in a Doberman. Use the breed-specific preference values, and that accounts for all breeds, basically.
I was going to say, I think that's true across all breeds, because mitral valve disease is so prevalent and the EPIC criteria are so well known and well discussed that, of course, a lot of practitioners revert to these normalized dimensions because that's the default in mitral valve disease. I couldn't agree more. I think these breed ranges are super important for Springer Spaniels, for Cocker Spaniels, for the sight hounds. I mean, they're so different to one another. They just don't fall into that normalized Cornell formulae.
Yeah. So coming back to your question, yes, we still measure it. We still look at it, but I trust the Simpson measurements. We measure them from the right side, from the left side, and then we take basically the larger one, because you cannot overestimate, but you can underestimate by bad echo views, basically. So then take the larger one. And in one of these studies, we have shown that it's more sensitive, but yet very specific to use the Simpson. And we proved that in longitudinal studies. Yeah. I gave a presentation a couple of years ago at ECVM or ACVM, and the speaker after me was a professor from the Mayo Clinic. They are leaders in echo, and he was following our discussion. And then he said he's surprised about this discussion, M mode or volume measurements, because in his lab, he let them measure M mode and volumes, and at the end, his residents have to delete the M mode. I'm
you can
not
do it,
going
but I'll
that
kill
much. No. It's still good to do M mode, but if you do M mode, I would highly, highly recommend to measure also EPSS, because this is the way how it changes my exam. This is such a quick test when I'm in the Plux view, parasternal long axis view from the right side. And then let's say I make a quick M mode through the long axis, and then just move the cursor and do EPSS, either there or in the short axis. But I usually start in the long axis. And then when I see EPSS is small, I know this will be a relaxed exam. If I can just eyeball EPSS looks a little bit large, or even it measures large, then I know, okay, that will be now more work, because I need perfect views from the right side, perfect views from the left side, 4, 2, 3 chamber views. We probably will measure strain. We do diastolic parameters and so on, because this dog has most likely the DCM phenotype. So just this quick, simple, and very old parameter, EPSS, is super. And it was actually better than just M mode.
So that helps you to stratify your risk.
Yeah. So it has been shown that internal diameters are different. They are not between short axis and long axis. The measurements are not interchangeable. Is EPSS interchangeable? Do you use long axis 4-chamber, 5-chamber, and short axis interchangeably, or is there a difference on EPSS also between short and long axis?
Well, now we come to an interesting question. It has been shown there is a difference between long axis and short axis, but then you have to ask yourself, why is there a difference? If you use a 3D probe in the long axis and you do it hard way, in the courses I always talk about easy way and hard way. Hard way means you go one rib spot more cranial and you look backwards and you go away from the sternum and scan more from inside of the thorax and look backwards. Then the heart also looks a little bit different. It is oval and it has not this bullet shape. Versus you do the easy way, you scan straight up and then the heart looks like a bullet. So if you do the hard way and then you do, you use your X-plane view on the 3D probe, the measurements are exactly the same. Why are they often larger in the short axis? Because probably we are scanning a little bit oblique. While you turn the probe, you manipulate it too much so that you cannot see, is the heart maybe too steep? And then your measurement would be wrong in the short axis, versus the advantage in the long axis is you can see if you are scanning oblique or not. And in the short axis, you cannot, unless you have a biplane view. So that as a comment, is there actually a difference between the short axis and the long axis in the internal diameter? And about the EPSS, I would say not. I also would not think that there is a big difference there. Most of the times I do it in the long axis, but I also do it in the short axis, the EPSS, and it should work.
Regarding normalizing volumes to body weight. So initially, you and others have used body surface area to normalize the volumes. And most recently, you have shown that you can also normalize it to body weight. Which one is better, or can you use them interchangeably?
Excellent question. So in the very first studies that we did about the Simpson method, we normalized them to everything, like body weight to a power of 1/3, but that is used for M mode. And then to kilogram and to body surface area. In the very first study that included only 300 dogs at that time, we found that body surface area and kilogram, they were very similar. But because in humans, they use body surface area to normalize, we thought, okay, we just do that as well. And for Dobermans, I still like that because we have so many data that I have no reason to change it to kilogram. But then when we recently published this normalized allometric study with 1,200 dogs, then we found that the theoretically correct normalization by kilogram is also the best that we used in this huge amount of data in different breeds. And also in that paper, we provide a cutoff value of, like, if you have LVIDD normalized to kilogram, then you have one cutoff value. And it's a quick thing because probably you also have it programmed into your machine. But if it's borderline, I still prefer the table, because the table is based on a special statistics where you don't have just a normal logarithmic line. We actually had these upper and lower normal values kind of were adapting, like a curvilinear adaptation to the data. And therefore, the table in that paper is actually better than just to normalize it by kilogram if you have an average breed dog. That works pretty nicely. I still look in my machine when I do the quick thing. We have the normalization to body surface area for the breed-specific ones, and also the kilograms. In Dobermans, Boxers, Salukis, and so on, we only use the body surface because we have data. In the other ones, if it's a mixed breed dog, I look at the normalization by kilogram as a rough thing. And if it's borderline, I take out the table and look at the table, because the table is more precise. I mean, the very advanced one you can diagnose with any diameter. You even can use fractional shortening for that.
Even fractional shortening.
Even fractional shortening. But I'm just kidding about fractional shortening all the time. Because fractional shortening, when I started here, I got a couple of dachshunds referred for DCM second opinion based on fractional shortening. And I mean, a dachshund doesn't get DCM, and this was just a wrong measurement. If it's measured correctly, then the parameter is probably okay. But I'm just always trying to teach, don't refer on one single parameter, and especially fractional shortening without end-diastolic and end-systolic enlargement cannot be correct, a low fractional shortening.
It's called dilated for a reason.
Yes. Well, there are systolic dysfunctions as well. And for example, we were talking about strain. If I have an end-systolic diameter enlargement, I always measure strain, and I want to confirm what we see. Or if we have regional hypokinesis, we want to confirm that. We always measure strain.
So we talked about linear dimensions a little bit, and we've talked about normalizing for body surface area, body weight. I have two questions actually about echo. One is slightly more advanced in inverted commas measures, like speckle tracking based techniques. So thinking about strain rate. Is that something that you would use routinely, either as part of your screening protocol? And if so, how? And the second part of that is, would you use it in cases that have got overt DCM? Do you think those advanced techniques hold any value for prognostication or risk stratification?
I think strain will stay. Strain rate, maybe not, because strain rate, even with speckle tracking, is still too noisy to the reproducibility. In my
I'm glad you say that, because I find it very noisy.
Yeah. Strain is a quite robust method, and it's quite easy. You have a steep learning curve. I mean, the main goal would be to diagnose the disease earlier than right now. And we have several studies running. The first step was to establish, again, using speckle tracking methods, normal values. And there are a couple of studies already published, and there will be more coming out. Also in the global longitudinal strain, using 423 chamber views, which is now kind of also in the guidelines of humans as an additional tool. And I think we will come there. It was a little bit the same with tissue Doppler, tissue velocity. If you think back, 10, 15 years ago, it was still quite new and only in high-end machines. Now it's included in every machine.
Everybody's got it, haven't they now?
Yeah. And in certain diseases, it's very useful. And it will be the same with strain. This is what I'm predicting, because this is a standard parameter now in humans. We still need a few more data, because we have done strain evaluation using the color tissue Doppler technique quite some years ago. There was too much overlap between the groups. But that might have been because of technical issues, that we made segmental analysis, like base, mid, apex, and then you had so many individual numbers, and they were not so good reproducible. Now, with these methods, if you give these loops to some people and they just follow the instructions, it's very good to reproduce. And we are getting probably more and more in the future this artificial intelligence and AI analysis, automatically analysis in the future, and then it will be included. I'm very sure about that. But I cannot say that I use it on a daily basis in screening, because now we know the normal values, but I don't know which value would put that dog into a risk. This is the next step. We will do that. We are currently doing that, but I cannot give you a number yet. There are software differences between different vendors. they are working on that if you measure it with a GE machine, that you get the same results with a Philips machine or a Tomtec or
Sure.
Siemens or whatever. They formed groups and they are getting better to harmonize, but probably it's also for the individual patient. I think there is a big thing that if you start with a Doberman screening, you have its baseline, and then the dog comes back, and then you can compare again, how is the strain now? I think this will be an interesting part, as we do with our heart size. I always ask or look up, how big was the heart last time in diastole, in systole, and how is it this time? Oh, it's still normal, but it gets bigger. Okay, we have to look at this dog a little bit closer.
Yeah, I think that change and the rate of change is important, isn't it, in most of the diseases we see? But I think it's underrepresented in the literature, maybe, and I think the rate of change is not something that many practitioners think about. They think about the diagnosis on the echo when they might see a case. But I think actually a lot of the nuance in decision making for those long-term cases comes from that serial echo and the change over time. And my second question actually is going back to linear dimensions. We've not mentioned left atrial size. And when we talk about mitral valve disease and we talk about hypertrophic cardiomyopathy, we focus a lot on left atrial size because obviously it's a big part of risk stratification, the decision to intervene with treatment. Perhaps it's not such a big part of dilated cardiomyopathy. Our discussion hasn't gone there yet. And we treat with pimobendan when we diagnose stage B with systolic dysfunction, chamber dilation. We're not thinking about adding pimobendan only based on atrial size as we would in mitral valve disease. Where does the assessment of left atrial size come in for you? And does it influence your decision-making in terms of treatment or discussions with owners about sudden cardiac death or risk of heart failure?
We are looking at the left atrium, but it will only dilate in late stage B2, because it would not, like in mitral valve, where we have the blood going back to the left atrium, it will only dilate in the more advanced stage. And we would use it as an assessment of the development of congestive heart failure, so of stage C. And LA to AO in the short axis, but recently I love more and more just the long axis normalized to kilogram to the exponent. That is really good.
You mentioned left ventricular fraction or shortening, which is great that you stressed that, because it will be very important to the listeners. Something that I always thought interesting was regarding LV injection fraction. That's a big one in humans, isn't it? To define the disease and to define prognosis. They look a lot at LV injection fraction. And looking at your data, both end diastolic volume and end systolic volume are related to sudden cardiac death. So is it different? Do you also look at injection fraction in dogs? Because looking at the stats, I would think injection fraction would be a big one, would be up there. Why is that not the case?
Oh, it is the case.
Okay.
Ejection fraction was in this sudden cardiac death paper. It was going parallel with LVI, left ventricular and diastolic volume and systolic volume, and ejection fraction. In humans, ejection fraction is actually number one detector or predictor of sudden cardiac death. And this is why we had included that in that study. Yeah. But because they all three parameters
are very correlated, right?
Are correlated. The software had to pick one.
Of course. Okay, cool.
Cool. And your reason why we are not using it more is, I actually don't know, because most of the studies started to generate just end diastolic and systolic volumes and not so much the ejection fractions. And I still like to look at those two parameters separately to know, is it more volume overloaded or is it more systolic dysfunction? The ejection fraction correlates quite good, and the cutoff value would be probably around 40.
We have this tradition of talking about biomarkers. We need to talk about biomarkers in every single episode with mixed feelings. But you have published a lot on biomarkers, and we have talked about screening and so on. Can you tell us when are biomarkers useful in screening, and what is the right biomarker for B1 versus B2?
I love biomarkers.
Okay.
I love biomarkers because they are good if you ask the right question.
Right.
And this is our job of the experts, to educate our colleagues what is the correct question. If your question is, does this dog have mitral valve disease? Just use your stethoscope. This is the best biomarker. You don't need BNP. Every dog has a murmur that has mitral valve disease. On the other side, it's very useful, in my opinion, in diseases that are not so easily to detect clinically, in feline cardiomyopathies and in dogs with cardiomyopathies. Where do I see a purpose? It's a good pre-screening test. So if you have dogs, and there are countries where you travel 3 hours to the next cardiologist, in Sweden, for example, and there is a Doberman or another large weight dog, and the owners hear now, okay, I have a Doberman. Do I need to travel 3 hours? What you could do as a practitioner is to use, for example, NT-proBNP, which will predict echocardiographic changes, so the phenotype DCM, or you pick troponin I, which would be a slightly better for detecting arrhythmias. So in my opinion, NT-proBNP really good to predict cardiac enlargement. Troponin I, a little bit better for arrhythmias. For the perfect screening test for stage B1, none of them works, because there we have the arrhythmias. So there you probably cannot replace the Holter by a biomarker. What you could do is you run quite long ECG in your practice. If somebody is doing an echo, you have an ECG attached. And if you see one VPC in a Doberman during your echo exam, that means the likelihood that this dog will have more than 100 in 24 hours is very high. On the other side, it's not very sensitive. So you can tell the owners, if you collect arguments, I think we need a Holter in this dog because I saw now 1 or 2 VPCs and the likelihood is very high. In some countries, echo is very expensive. Then maybe a pre-screening test using one or both of these biomarkers would be good, in my opinion.
To flip it around, there are countries where biomarkers are super expensive, and echo at a general practice level is very accessible. I remember years ago, I want to quantify this, is quite a long time ago. I presented in Russia and I did a whole lecture on biomarkers, and I'd suggested the title and they'd approved it. Fantastic. Did the talk. I was really happy with how everything went. At the end, somebody put their hand up and said, given what you've said, why wouldn't we just do an echo? And
Absolutely.
I said, echoes are probably kind of expensive, and biomarkers would be cheaper, and how many of you in this room are doing echoes? Everybody put their hand up. 500, 800 people put their hand up. I said, whoa, that's very different to the UK. And how expensive are biomarkers? Well, they were about 5 times the cost of an echo. And I did exactly the same thing a couple of years later in Brazil. So there are definitely countries where biomarkers are inaccessible, and echo is much more accessible. And for those guys, obviously, it's a no-brainer. Echo is the way to go.
Absolutely. And do I biomarker? Do I do them? Well, I don't need them. But there are sometimes, troponin I is quite good marker. Sometimes it's already increased slightly.
Yeah.
While our echo and the Holter is still normal. So we call that the last normal exam in one study. And so these dogs, because they're in our study, they would come already after 6 months back for the next exam, but they don't have to pay much anyway. So, and I completely agree. You have to keep the costs in mind of the biomarker, but maybe the cardiologist, there is no cardiologist in this area as a pre-screening test to collect arguments. This is a good thing to send them to the cardiologist, and in some countries where echo is expensive. If echo is cheap, do the echo, of course.
What you just mentioned is an area that I have a lot of interest on, and you had so to detect if we want stage A dogs just before overt dilated cardiomyopathy, just before they develop any signs of dilated cardiomyopathy.
Stage A plus.
And
A2.
yeah, you have this data, as you mentioned, that both also BNP detect earlier disease than echo and Holter, didn't it? Is it something you are still looking at, a marker that will detect disease before overt DCM?
Well, we are looking at some in-house biomarkers that are cheap and that could be run by normal practitioners for the A+ stage genetic test. That would be the thing.
So the PROTECT study, just for maybe the very few people that may not be aware of the PROTECT study was a randomized clinical trial that has shown that pimobendan given to dogs, Dobermans with occult stage of DCM, giving pimobendan would delay the occurrence of clinical signs, congestive heart failure, standard cardiac death by 9 months. So the PROTECT criteria were linear measurements. They based their criteria to start PIMO on right person or short axis, even I believe linear measurements. What are your criteria to start pimobendan on Adobe? Do you also use linear measurements or would you use volumes?
We still would use our volume data, and you have cutoff values, what is normal and what is abnormal. If you have 55 as a systolic parameter, for example, in a Doberman, would I start pimobendan in a dog that has 56 milliliters per body surface area? Probably not. I would probably say, okay, we have a starting systolic dysfunction, and maybe we make another exam in 3 months and take a look. And then if it's confirmed, then we start. I want a clear diagnosis. Not saying that 56 is not clear, but I mean, 1 milliliter you can adjust by measurements. And since they are kind of correlated, the linear measurements and the volumes, I would also do the same with the linear measurements. Only if you have clear evidence that there is systolic dysfunction, then I will start.
I think we'd all be happy if we make a confident diagnosis of dilated cardiomyopathy to begin pimobendan in the asymptomatic phase. Is there a scenario where you would start treatment with some RAS inhibition, some ACE inhibitor such as benazepril or spironolactone in the asymptomatic patient? Would you use it in stage B?
I mean, the data on ACE inhibitors, for example, in humans, in DCM, they're not bad. And whereas I don't see any point in mitral valve disease to give it in that phase, in DCM, I see a point. And there's one retrospective study from Mike O'Grady with all that doubts a little bit because of retrospective nature, but at least this is better than nothing. And we have actually a prospective study on that topic also ongoing. I just need to pull out the data and just see if it makes a difference. The study is already quite long ongoing, too many studies, but big data probably.
Yes,
and then I can give you a more evidence-based answer, but I see a potential for an ACE inhibitor in the asymptomatic phase in stage B2.
And spironolactone at the moment, is that something you consider using in the asymptomatic patient, or in fact in the stage C patient?
I mean, if you give the Cardalis, for example, as a combi product, you get 2 drugs in one. If you want to give one, why not give 2 in one pill?
Sure.
That would make more sense to me. There was also a recent paper in Dobermans in congestive heart failure and the outcome. I mean, the add-on of spironolactone was not that super convincing, but it would be included in our part anyways in congestive heart failure as a sequential nephron blockade.
Yes.
Where we start with toracimide or furosemide and then add maybe spironolactone and add later hydrochlorothiazide.
Yeah, you mentioned they're humans and that ACE inhibitors are useful in humans. Something that is always very striking is beta blockers are very useful in humans and used as a first-line treatment in dilated cardiomyopathy. Why is that different in dogs? What's your thought about beta blockers on preclinical dilated cardiomyopathy?
I start to cite humans, but humans are actually not a good model for us because most of their DCM comes from post-myocardial infarct. And this population is just different than the dogs that we see. And if you look at the data, most of the effect that beta blockers, ACE inhibitors, RAS inhibitors, and so on, is actually on lowering the blood pressure. High blood pressure in humans is the major one cause of having problems. And I think we all agree that in dogs, it's not that big problem. I think the beta blockers in the later phase, carvedilol, was very long hyped, also in veterinary medicine because of the Copernicus studies and others in humans, where they even gave beta blockers in heart failure. Initially, everybody was scared because if you give a beta blocker to a human in heart failure, you would think you reduce the contractility. On the long term, it was actually better. And then I still remember when I was a resident and Mark Kittleson was sitting with us in Journal Club, and he put $50 on the table and said, if anybody can prove that a dog has an increased contractility on carvedilol, here are the $50. And these $50 are probably still there on the table because many people tried it.
The value depreciating every year goes unproven.
Yeah. Many people tried carvedilol, and nobody can show that they have an increased contractility anymore. As a anti-arrhythmic drug, it's not very good. We tried that also at the beginning. It was a little bit disappointing, so we stopped doing that.
You just mentioned antiarrhythmics. So $1 million question, and I know we have no data out there, but still, what's your first line antiarrhythmic for ventricular arrhythmias? Well, when would you start to treat ventricular arrhythmias, maybe first?
Based on the malignancy criteria, which are my most important, is to look for RNT and the Vmax, which are correlated. The Vmax, if the velocity is more than 250, 260, then we start treatment. And as we discussed before with the sudden cardiac death, a big heart triggers me much more. So the phenotype DCM to start and use antiarrhythmics. Because many private practitioners are listening to your podcast, I think it's very important to mention also that there are a lot of VPCs that are slow, and we call them accelerated idioventricular rhythm. So a VPC with a rate between 60 and 160, 180. I just call them differently, accelerated idioventricular rhythm, just to take away the burden from the shoulder that you need to treat that. Because if you say, okay, there are 4 in a row, how do you call 4 in a row? Well, this is a VTAC. But if it's slow, it's not a VTAC. A VTAC means, yeah, I need to treat. But if you call it, yeah, there are 4 beats of accelerated idioventricular rhythm, you don't need to treat them. So the speed or the beat-to-beat frequency of the VPCs, this is very important for me. The numbers of couplets, triplets, or VTAC salvis on the Holter, those would be all malignancy criteria. And then which drug would I use to use? I don't want to influence anybody here because, again, we started 20 years ago. I was sitting there, and then I was thinking how to make cool Doberman studies. And then I set up, 19 years ago maybe, different legs, like where I said, this is a dog that has no echocardiographic enlargement. He has just arrhythmias. And then what kind of arrhythmias? Malignant or benign? Different legs, different studies, how they get prospectively randomized to get the drug. And the same then if the heart is enlarged. Are they malignant? Are they kind of benign? Different treatment options. So I have maybe this 1 million question answer, but I need to do the analysis. And I think now
Oh,
when
you
it's
tease us. I was waiting then. For that.
when the 20
It's
year is
digoxin.
full. So I mean, in these lakes, I can tell you what is in these lakes, but I cannot spoil which one is better because I don't know. Honestly, I don't know.
Watch this space.
Yeah.
Wow.
I will come back to the podcast once we have the
Exactly.
results.
Oh yeah,
Exactly.
we're thinking
announced
about
it
doing
here.
a research podcast where we discuss with researchers the content of a paper.
Absolutely.
So let's do it. Let's book you for that right now. That sounds
And
great.
everybody who likes that podcast, please don't forget to give a like.
Subscribe.
Subscribe.
Yeah, so
Subscribe
that
and
you
share it
will
on the
get
socials,
the
yeah.
updates on that. So what do what do we do? We have, for the very malignant ones, we have either amiodarone versus sotalol, initially in combination with maxilitine, or now in combination with flecainide. And then the other legs are sotalol alone, or some non-antiarrhythmic drugs, to see, then we know which one is working. We had one thesis about that topic, and the difference between amiodarone and sotalol plus mex was not big. So it's not a clear winner. Otherwise, we would have already presented some data. This has been presented, but only as a doctoral thesis, and that was already 10 years ago. We all know, I mean, Clay Calvert always told me, if a Doberman has these malignancy criteria, or if they have a syncope, you need to treat them, otherwise they drop dead. He learned it hard because his own dog dropped dead many, many years ago. But we don't know which one is the best one. I think they are both very good. I'm just reluctant to say amiodarone is so good, because many people listen to your podcast, and amiodarone is a dangerous drug.
It's a dirty drug, isn't it?
I think we should teach about amiodarone as it is done in humans. It is the last drug that you use after you have used a bunch of others. Before you implant a defibrillator.
Right.
And I think if we can bring that message to all these veterinarians there, because I have seen actually dogs on, I should not say that, but 3rd-degree AV block with a ventricular escape on amiodarone, because somebody thought this needs to be treated. So I think we as experts need to be also careful to educate. This is a drug, it is potentially very good, but it also has bad side effects. Liver enzyme elevations we see frequently on long-term use in Dobermans. Sometimes, not all of them, but sometimes we see that. This is probably the most side effect that we see in Dobermans. It is an effective drug, but as you said, Kieran, dirty or dangerous. So only use it if you maybe consulted with the expert of your choice about arrhythmias. I think, don't forget that. If you're trying and you have this really bad ECG, there are cardiologists where you usually refer the case to anyways, and everybody will be happy to help out and say, yeah, this one I would not try first, something else.
Pick up the phone. That's an incredibly positive message to end on.
Can I ask you two cheeky final questions? One, Gerhard, is sotalol. How worried, nervous are you to giving sotalol to a dog with systolic dysfunction? We discussed that a lot. Okay, there is systolic dysfunction. Of course, sotalol has some beta blocker effect. Are you worried? Do you have seen dogs that you start sotalol and then they decompensate? What are your thoughts on that?
We are always routinely titrating up sotalol, everything with an OL at the end. Sometimes you have to make the individual call that this dog had a VTAC with more than 300. So he's a high-risk patient. So you probably don't want to titrate it up over 1 month, starting with a quarter of a dose and then next week half. Here I would go in faster, and I would then, for this period, double the pimobendan to counteract that negative inotropic effect of sotalol, or whatever other drugs you use. But I'm not super worried to use it in DCM, even advanced cases.
Sometimes there is this concern that dogies may be more sensitive to amiodarone and may have more adverse effects. Do you see that or not really?
I mean, Dobermans have per se more liver problems. I mean, have a high prevalence of liver problems, independent from the heart. And maybe they have more problems, but maybe it's only because this is the breed where we use it most commonly. But we also use it in other dogs. One thing maybe we have seen German Shepherds with probably inherited ventricular arrhythmias, and they have been on previously, they came with us on sotalol. And I think one message is for me that sotalol as a single drug in German Shepherds is probably not super good, because it has been shown by Anna Gelzer that it might be pro-arrhythmogenic. And actually in that dog, we took it off and then they were much less. But the dog still had malignant ventricular arrhythmias. And here we used an amiodarone as an example. The numbers of dogs on amiodarone are not so high in other breeds where we can say they don't get liver problems.
Brilliant.
So what we tend to do at the end of our podcast is to ask our esteemed guests for their top 3 take-home messages for the listeners. So I don't know if you can distill the last hour's conversation into your top 3 practical points for people.
Okay, my top 3 take-home messages is talk to your clients about their breeds. Inform them about the disease. Oh, you have a Doberman. Do you know the disease exists? And tell them, inform them. Then top 2 biomarkers can help for pre-screening. So, and then concerning echo methods, we talked so many about volumes. Of course, I love volumes and advanced measurements. For sudden cardiac death, it's not the number of VPCs, it's more the malignancy criteria, including the beat-to-beat frequency, the fastest rate. And that actually makes the Holter time-consuming, the analysis. We look at every single VPC and look which one is the fastest. And this is not automatic, this is manual things. The key also for DCM is to do screening exams, because as we said before, mitral valve is easy. Every dog has a murmur. DCM dogs, maybe, maybe not, probably only a soft one, if at all. To select the correct dogs for screening is very important.
Great stuff. Thank you so much, Gerhard. That's a fascinating conversation and some really important take-home points.
It was a pleasure to be here with you guys. It's fun.
Yeah. Thanks very much.
So thanks everybody for listening, and thank you to Dr. Wess for taking part in our podcast and talking to us about dilated cardiomyopathy in dogs. We have got some guests lined up for the future, and obviously you can stay up to date on our forthcoming episodes and release dates on our socials. So on Instagram and on Twitter, our handle is @heartbeat_pod. Thank you very much, everybody, for listening. Bye-bye.
Bye now.